really excited to bring Dr. Humphries. Doesn't really require an introduction to people here.
So today what I want to talk to you about is what I think is the future of medicine. And I don't have 40 objectives, but each one of these objectives does need to be drawn out a little bit, and I'm going to try to go through them. And I also have an 8:30 case, and I realize I'm going to get dinged for a late start, so I'm just going to roll with it and try to breathe into being late today. Telehealth and telemedicine. I recently received a K award from the NHLBI to explore how to implement telemedicine throughout rural clinics. And I do believe that this is the future of medicine. The younger generations are much more savvy with telemedicine, and they appreciate it. Patients, even in urban areas, cannot get to us. They cannot take a 5-minute lift. They do not have the resources to get here, and they can't come in for their appointments. So while I love the idea of telemedicine in rural California, and that's what I'm focused on, I understand that it's also an urban issue. Telehealth is the umbrella under which telemedicine sits. When you think about telehealth, we're talking about remote care and monitoring, so tele-ICU, wearable technology. Smartphones are able to track things. We do have pathways to bring some of that information into our EMR, and we're constantly developing new pathways to bring that information in. E-consults, which I'm not going to talk a lot about, but you have seen coming across in all of your areas, and it's now a particular thing that is reimbursed. So you can get reimbursed for actually telling somebody, I think you might want to do this or that sideline that you get sometimes where it's like, hey, could you look at this CT scan? Send an e-consult instead. There's reimbursement for that now. And while I don't think that we need to be, while I'm not going to focus too much on it, we need to be paid for what we do, and that stuff takes time and effort. Store and forward imaging evaluation is also something that is newly reimbursed, but it is part of telemedicine. And then there's the word telemedicine itself. And we're going to go through a couple of these. So store and forward imaging is how telemedicine started. And when I use the words telemedicine, sometimes I will use them interchangeably with telehealth, and that's because the definition has changed over time. It's only been about since 2013, 2014 that they've separated telemedicine off into its own kind of field. But store and forward imaging is where telemedicine started, and it started with dermatology. And basically, this study that they did looked at 3 different phases of 2009 patients. And I'll bring your attention down to the 3rd phase, which is where they took these referrals and they compared them to face-to-face evaluation. And what they found is that if you sent in images of your skin cancer or your lesion and asked, is this malignant? They were very good at determining if it was malignant or not. And so they did a study where the gold standard was an in-person visit, and they compared it to teledermatology. And what they found was that the sensitivity of this consult, whenever they sent in images and a little history about it, was 0.99, and the specificity was a little bit lower. But they were very good at saying that is a true positive. And for the other ones where they were a little unsure, they brought those patients in. From dermatology, the plastic surgery literature is really where telemedicine moved next. And this is a study by Merrick Dodick, who I do not know, but he used to be the chief of plastic surgery down at UCSD. And basically, he took 120 patients who had chronic wounds. And they looked at, or they sent in a referral, and with that referral, they sent in a history and photographs. And they came up with a plan, and then they brought the patients in, and they saw the wounds and evaluated the patients, and then they looked at, and they developed a definitive treatment from there. And when they compared the treatment plan from the store and forward referral to the treatment plan that they came up with the in-person visit, there was about a 94% correlation between those two. So it is feasible with good imaging to look at a wound, to look at a lesion, to potentially look at something and say, this is going to be the plan for that. He later took the study one step further, and he asked primary care physicians about how they felt regarding these particular interventions. And one of the things I thought was interesting with this is he surveyed 36 people. He got 30 of them to respond, which is a really good, that's 83%. That's probably the best response rate you ever see in a survey. And I'll explain a little bit of that why later, but 60% of the primary care physicians who received a response from the store and forward imaging as this is what we would recommend that you do, were comfortable enacting that. Primary care physicians are not very comfortable with wounds or the management of it, but they did feel, 93% of them were pleased with the idea of having the store and forward program because they felt that it expedited care for their patients and it really enhanced the care that they delivered. And over time, they felt that they were able to take better care of their patients. So store and forward is one form of telehealth. Telemedicine is a two-way, real-time interactive communication between the patient and a provider at a remote site. And there are two pathways for telemedicine. One of those is direct to consumer. And the second is where you are doing remote clinics or some type of more formalized clinic version. And direct to consumer means the patient is at home, or sometimes they're in their car, although we try to tell them not to do that. We try to tell them to be in a place where there's static Wi-Fi, but they are somewhere outside of a clinical area, and they are using their own personal technology. So they may be using, sometimes they're even using public technology, public Wi-Fi, but they have a smartphone or a tablet, or potentially they're using a desktop version of some software. A remote telemedicine clinic is slightly different. The patient is either in some clinic, maybe in a rural health center or an FQHC. Sometimes these are urban areas that have connections with other facilities. There are requirements through reimbursement, and sometimes the primary care physician has to be present in those, and I'll talk a little bit about that when I go into reimbursement. And there's usually a physical exam support person so that you can do a surrogate physical exam or get some of the information that you need. And finally, the remote physician can use some type of camera that may be controllable. So this camera up here is a very fancy camera where you can control it and you can move, you can zoom in, you can zoom out, and you can kind of look at the patient and you control where you're looking versus the support person maybe moving the camera for you. There are a lot of barriers to telemedicine. So I received my K award in April, and I had a plan for how I was going to implement 5 telemedicine clinics, and I have implemented 0 telemedicine clinics. And we're gonna go through the barriers to that because I'm in that failing fast mode right now. I'm failing like every day so that I can figure it out and I can move forward. The biggest impediment to doing telemedicine is actually reimbursement. And this was something I really didn't appreciate. All of the current telemedicine clinics at UC Davis are contracted clinics. There are no real fee-for-service clinics, meaning a hospital says, oh, we want you to see a vascular surgeon. You're going to just see this person through the internet in a time whenever we choose. Mostly what it is that the hospitals, and a great example is Barton, they work with Stu Cohen, who is an infectious disease specialist. He sees a half a day a clinic, 1 day a week on Tuesdays. They came to him as part of some of their need and said, we need an infectious disease specialist. And we said, we can do this and we can help you through telemedicine. That is how most of the clinics at UC Davis are run now. And we have clinics in dermatology, nephrology, endocrinology, rheumatology. So we're going to go in depth into reimbursement. UC Davis is where telemedicine started in California in 1992. Tom Nesbitt launched telemedicine here. He is one of my mentors for my K Award. and other facilities followed thereafter. We needed legislation by 1996, and the first Telemedicine Development Act was put in there, and that was a Senate bill, which basically said that if you wanted to do telemedicine, you had to have written consent from the person, but you did not have to have a face-to-face contact between the patient and the healthcare provider for the services that were ultimately going to be delivered by telemedicine. And I know that sounds silly where we are now, but back then they did not really fathom what this was going to turn into. The Telehealth Advancement Act in 2011 was really something that helped to clarify a lot of the definitions of what telehealth was and how it could be delivered. It also was a huge win for healthcare in California because it mandated that private payers reimburse for telemedicine services. So if you wanted to provide healthcare in a private, or if you were a private company that wanted to provide healthcare in California, you had to reimburse for telemedicine visits. But the problem was you could reimburse it at different rates. And that's a bill that I'll go in just a minute. In 2003, there was additional money that was given to kind of expand capital investments. And this also took away the private hospital's ability to limit where telemedicine can be done. And this is going to become relevant whenever I talk about Medicare. And then finally in 2005, it was changed to where you did not need written consent to do telemedicine. You can now do verbal consent. And you'll see me do an example of that in a little bit. The most recent legislation was in 2019, in October of this year. And these two bills have been something that a lot of people are excited about. Assembly Bill 744 basically said that if you provide private insurance here, you have to pay for telemedicine services just as you would for in-person services. So you get paid the same amount if you do a level 2 established patient in person versus if you do it through telemedicine. And that's a big win. This bill will not go into effect until January 2021. But that was a big win that the groups have pushed for. Covered our Center for Healthcare, or Center for Connected Health is the group that really works on that in California. Assembly Bill 1264 took place immediately. And I don't know if some of you remember Dr. Farmer talking about prescribing for people several months ago in Grand Rounds. But what this said basically was that you cannot prescribe a prescription for someone without having prior done a physical exam. It's considered unprofessional. And you could be brought up on misconduct if you do something like that. But the way telemedicine fits into this bill is that the prior exam does not have to be done at the same time the prescription was done. And it could also, the prior exam could have been done by telemedicine. Truly what this bill was designed for was contraception. So there were barriers to women getting contraception, and the legislation that was in place, or the way that healthcare providers, not our insurance providers, were limiting certain things. So that's really what the impetus for this bill was, but it's still added to what we can do in terms of telemedicine. And while private insurance in California and Medi-Cal are way ahead of the game, my biggest problem is that my patients all have Medicare. And if you did not know this, the federal government is way behind where California is on most things. That might be a shock to you, but Medicare has very specific requirements about how telemedicine can be done. For one, the originating site, meaning where the patient is, has to be one of these particular things that are listed here. It has to be a physician's office or a hospital. It can be a FQHC or a rural health clinic. The only way that you can do direct-to-consumer telemedicine for Medicare is if the patient has some type of home dialysis unit. I didn't even know that was really a thing, but apparently it is. And they really limit where some of these physicians and practitioners' offices or hospitals can be. They have to be in a rural shortage area, located in a rural census tract. And this is a website that I use all the time as I'm going out to some of these clinics to figure out, is this place actually in a rural area so that I can do telemedicine with them for Medicare? The distance site requirements, so that's where the provider is and who can provide those particular services. This is really the distance site requirements. So it has to be one of these people providing the telemedicine services. Nurse practitioner and PAs are included, even registered nurses, nurse anesthetists. But you can have social workers and dietitians or nutritional providers. In the recent legislation, there were some changes. So home-based dialysis is one of the exceptions where you can have direct-to-consumer telehealth. Telestroke, January of 2019, was expanded so that there are not the limitations for rural health. You can actually do telestroke in multiple places, and it is why UC Davis is trying to push and to bring its telestroke program up, because they're no longer the same Medicare limitations. The 4 in green are new legislation that has recently come out, which allows you to be reimbursed for opioid addiction treatment in a direct-to-consumer fashion. Virtual check-ins. A virtual check-in is when you do some type of interaction with the patient that, one, is not something the patient has been seen or treated for in the last 7 days, and does not result in the patient coming in the next 48 hours. So if you do a communication with that patient through MyChart or something like that, technically you could bill for a virtual check-in, but there are some limitations around it. And before you start billing for some of your MyChart communications, I would advise you to really look into those and how to do it. E-consults. So this is also new legislation that just passed. It's why you're seeing us trying to move providers to using the e-consult system. Work smarter, not harder. Get paid for what you're actually doing. You deserve it. And then remote evaluation of patients' photos or video is another area where you can be reimbursed. The patient sends you in a video or a photo, you can actually evaluate that and return a diagnosis or information. And again, there are very specific limitations around that. So before you just willy-nilly do it, you have to kind of go through those steps and evaluate that. Referral patterns is another extreme barrier to telemedicine, which I have found has really become part of my crux. So this is a map of California, of Northern California, that was created by an analyst, a junior analyst that I work with, who's wonderful. The blue areas are areas where there are wound care clinics, and there are areas where people have wounds that are getting treated. The red dots are places where there are vascular surgeons. And actually down here I forgot about this. In here in Sonora, this little red dot is actually disappeared because those people retired. People like to send patients where they have been sending it and where they get a good response, closed loop communication, and it's an easy pathway. So one of the greatest examples is Placerville. It seems very simple to come right down here. This particular hospital does not want to work with me because it's too hard to get your patients into UC Davis. It takes too long for them to get appointments. They get no communication back from us. And there's a laundry list of reasons why right now we really are struggling to kind of build ourselves back up in the community. And this is something that I'll come back to in a minute. Provider resistance is something that's also prevalent. For many people, they believe, and while physical exam is essential for so many parts of being a practitioner, a lot of what medicine is your interaction with the patient too. So for certain fields, it is highly unrealistic that you would be able to do everything by telemedicine. For instance, hernia surgery. It is hard to determine what the boundaries of the hernia are through telemedicine, but there are surrogates that can be used. And when you're thinking about doing telemedicine, you have to start thinking about surrogate ways to do physical exam. For my purposes, if I'm looking to do PAD, the surrogate exam is using a Doppler. So we have the physical exam support person in the telemedicine clinic use a Doppler at the femoral region and also in the foot to listen to what the flow sounds like. Is it triphasic? Is it monophasic? And that helps to guide whether we're going to do imaging, such as an ultrasound or a CT scan, or if we're going to bring the patient in immediately and just go forward with an angiogram. So you have to think about surrogate ways to do the physical exam when you're talking about telemedicine. And that takes providers that are open-minded and willing to think outside of the practice they have done for the last 30 years. And then the lack of personalization for the patients. That is something that is mostly provider-driven to fix, and I'll talk a little bit about that in just a minute. There are numerous studies in the surgical literature looking at telemedicine, and I've listed several areas here because I can't go through all of these studies. But the literature is full of studies looking at preoperative consultations and surgical planning, as well as postoperative visits. And it is my understanding that in Colorado, 60% of all of their postoperative visits are done through telemedicine. That's a huge number. The goal for UC Davis right now for video visits in each clinic is 1%. Their 60% seems to be leaving us behind a little bit. But each one of these areas has studies that have shown that telemedicine works for them. And I'm going to break down a little bit of the postoperative and preoperative studies to give you what the synopsis of those were. In the postoperative visits, when you aggregate all of these studies and you look at them, really what they say is that telemedicine is comparable to in-person visits for postoperative wounds, for managing drains, all of those things that we have people come in to look at paper or something along those lines. It's very easy for them to do through telemedicine. In transplant surgery, using telemedicine increased medication adherence, and it also decreased return visits to the transplant clinic and hospitalizations. Patients like it because it decreases travel time for them to the clinic or the hospital. And many patients actually feel that it strengthens their relationship with their provider because they feel that they get better care and they're connected. Even though you may not be interacting with them more, they still feel this way because it may be your nurse or some clinic. They feel safe. They feel like there's always somebody there for them. When it comes to preoperative consultations and surgical planning, this part of telemedicine is a little bit harder. The studies that I think of whenever I look back at this are ENT, vascular surgery, and acute care surgery. Those were the three areas that really hit me. In both ENT and vascular surgery, telemedicine consultation was able to provide the same recommendations for care as in-person evaluation. And there are multiple studies in both of those fields. And essentially they had patients have their images and maybe their studies already sent before so that they could formulate these. In acute care surgery, the use of telemedicine prevented unnecessary hospital and ER transfers. We have a very robust emergency room telemedicine network from UC Davis, and this is an area that we could easily spin off. It also, again, decreased travel time for patients to the clinic preoperatively. But the one thing that was really, that struck me for a lot of these patients and what they stated was that it provided additional surgical options for these patients that lived in smaller towns or rural area where they were going to get their care, but now they had made the decision to come to a larger academic center or to a larger hospital, and they had other options. But there are some things when you are doing preoperative consultations that you really have to focus on. For one, patients are weary of getting surgical care or not necessarily meeting the surgeon before they say, yes, I'm going to let this person operate on me. So one of the ways to mitigate that is to have a very good relationship with the referring provider. So if the referring primary care physician or referring specialist in the area where the patient lives says, I think you should see somebody at UC Davis. And what's great is you could do it through telemedicine. That sets up in the patient's mind a relationship because that primary care or referring physician has already made you someone that is trustable to that patient. And that was really interesting in some of the qualitative work I did. If a primary care physician said, oh, you could see this person through video, patients were more likely to trust and go with that. Telemedicine specialists, meaning the specialty provider here, have to focus on building that patient-doctor relationship. And if you've ever FaceTimed anybody, you realize there's a lag. So in order to build that patient-doctor relationship, you have to do things a little bit differently than you would do in your in-person clinic. You have to speak slower. You also have to give time for each person to kind of complete their thought. And it sometimes seems a little awkward, but it's really inherent on the specialist to try and drive that, because patients can quickly switch to an area where they think this isn't working and they don't necessarily like it. And for surgery, it really is best used in cases where patients have already anticipated they're going to have surgery. They know they're going to need something done, and you can use imaging to help the patient understand their treatment options. And I'll try to give you some examples of that. So, how do you get started? This is where the nuts and bolts of most of what we are going to talk about comes together. Telemedicine is mostly provider driven. Your patients may not ask for it now because it is not so widespread. So if you want to increase the number of patients that you are seeing in your clinic through telemedicine, you really kind of have to drive that. This paper that's right here is available in all of the clinics. So in the vascular clinic, we have these in each and every room. We have them in the waiting room. In the Cypress building, they're also there. And it tells the patient about video visits. But if you say to the patient, you know, the next visit you have, we could do through a video visit, it puts it in their mind. Where we started in our clinic was really focusing on follow-up or post-operative care. So there's a specific group of patients that I see where they come to see me, and then they all have to go and get a study, and then we come back and talk about it. It's varicose veins. So what I tell the patient is the next visit, you can get your study whenever you want, and the next visit we'll do through telemedicine. And we go over their options for treatment, and they are very responsive to it, and they like that they don't necessarily have to come back. If you focus on a patient population there, it allows you to get started with the telemedicine and then find ways to expand it to preoperative care. And you have to set up your schedule to accommodate an on-time and easy start. And I'll show you what that means. This is my template for one of my clinics. And the red are the telemedicine visits, and you can see how they're kind of scattered throughout my clinic. This is when we first started. And this is a disaster because the 9 a.m. MyChart video patient is always ready to go at 9 o'clock, I promise you. They log on and they're ready to go. The problem is that the 8:30 patient that came in 10 minutes late. So then I didn't get started until this time, and then I'm running behind, and it ends up just kind of running into it. So, and then scattering them out. The 9:30 patient, same thing. Because I got behind with one of the other patients, or the 9:15 patient is actually ready to be seen because they've been had their vitals and put in the room closer to 9:30, but the 9:30 telemedicine patient is ready to go at 9:30. So it's not easy to scatter it throughout your clinic here, and I don't recommend that. What we do recommend is blocking it. Blocking it into your clinic, usually at the beginning of your clinic. So if you can do it at 8:30, for those of you that take a 30-minute break or some kind of break for lunch, starting on time at 1:30, whatever you may have natural breaks in your schedule, blocking those and putting those so that you can run them on time. I promise you the patients are almost always on time, if not early, and the visits do not take the full amount of time. My clinic is unique in the way that I actually go from UC Davis to Elk Grove. So the 12:15 to 1:30 break, I actually usually finish at about 12:45, and then I have to drive all the way to Elk Grove. So that's why I have a natural break in my schedule. But because I do procedures in the morning, we had to put them at the end. It always is a bit tricky, but blocking them and putting them in one area is really helpful. The other thing that you have to do is you have to set up a place to actually do all of this. So this is our telemedicine workstation in the vascular clinic. It is part of the good practices of care to not be doing telemedicine in the area where the residents are talking about another patient or presenting something, because patients on video can hear your nurse talking about Mrs. Carter, who didn't go and get her antibiotics, and now the infection is fulminant and she's going to die, and oh my goodness, patients can hear that. So you want to do it in a separate area, and this is our telemedicine area in the vascular clinic. We set it up to where I have a little stand, so you put your phone on the stand, there's a charger underneath it. We have headphones that are in a box off to the side here with little alcohol pads, so if people don't like my ear grease, they can clean it off before they use it. And essentially this is a little bit of a close-up there, but we also use dual screens. So we set it up so that you also have dual screens up there, because frequently I will be charting, and I'll show you that, and have images up to show patients. This is, again, the little stand. It makes it easy. In fact, I brought my little stand here today because we're going to do a demo, and I have my phone sitting here so that I can chart and type at the same time that I am talking to the patient. All of telemedicine is time-based. So if you're doing it in post-op, it's all in the global period. But if you are doing a different consultation, it's all time-based. So we have a little clock here that shows us what time we start. And so you can write down on that piece of paper. It's a telemedicine note page. You basically have the patient's name, the time you started, the time you ended. And then we actually keep a flyer here that tells you what the time is. And this is what it looks like. So you know, oh, I did, and most of the telemedicine that you're doing is really going to be time-based. So if you have a new patient, if you have an established patient, these are the times for each one and how you can bill. Because when you close your encounter, you have to do your own billing for telemedicine. And we keep this right there in the clinic, so it's super accessible and very easy for people. Like I said, we use a dual screen. And in that dual screen, that allows me to type on one side and to use images. And the reason that we do that is because it is frequently very easy for you. This is the telemedicine note. When your clinic schedules you for a video visit, when you open that encounter, it will look something like this. Since we're all using the widescreen version now, we've all had to transition. This is usually what it looks like. You see over here where it says video visit. And then this is the note that typically populates. You are required to ask the patient if they consent to the video visit. And so that is what this top part is. It is the legal jargon that says that the patient verbally consents to being done, or to telemedicine. And then you can write your notes through here. So how do you use it from the provider perspective? I use Haiku. Haiku is, you can also use Cantu if you are using an iPad. When you log in, just as when you log in with your Haiku any other time, you pick where you're working. And then this is what the schedule will look like. If you choose your schedule at the bottom of the screen, you'll see here. And you'll see your clinic schedule come up, and you'll see the video visits. You'll also see if the patient has already logged on. So this patient's appointment was at 12. Whoops, go back. And they logged in at 11:56. This patient's appointment is at 12:15, and this man logged on at 12:01. They're ready to go. They got things to do. If you click down here where it says more, it'll take you to notifications, and then you can see here exactly that the names would normally be here. It tells you who's connected, and you choose the first patient's name, and then it'll take you to a screen that says this: the patient is ready. So the thing about the way that I do video visits is that I do not go into the visit unless the patient is already in there. Because I'll be typing, or I might be talking to the residents. You really want to wait until the patient is set the video up or gone into the appointment. If the patient has not, it'll say this: no one has joined yet. And so I usually wait, or I go back to the notifications and wait until it changes. So how hard is it really? I would say that it's about this hard. You go into your schedule. You can see that the patient has arrived. You click on that, and you can go across, or you can go to notifications, which are here. And again, the patient, I already clicked on it while we couldn't see it on the screen. So shocking that the demo is going to be a little bit of an issue. But you can also go across to telemedicine, and when the patient is ready, you click on that, and then basically it'll take just a minute for the patient to pop up. And then on the top, you will usually see the patient, and on the bottom, you will usually see the provider, and then there you are. So this is Miss Colby, Rupinder Colby, who emails you, who you get emails from all the time about video visits. She's actually sitting over here on the side of this screen. And if you have questions later, or on the side of the auditorium, if you have questions later, she will be somebody that can help you to answer whether or not video visits are right for you, what you can do. So usually what I'll do is I'll look at her and I'll say, hello, Miss Colby, how are you? Or Miss Rangerette. And the first thing I ask her is, you know that we're doing a video visit today. Are you okay with the fact that our visit is through video visits? And so when she says that, it allows me then to keep track of it and to, in my note, to go ahead and acknowledge that. So we're going to get rid of this video visit, and we're going to go back to my talk. But what about if you don't have a smartphone or a tablet? Or what about the telemedicine visit that I told you we are doing in rural clinics? So this is, again, in our telemedicine area, we have a camera at the top of the screen. And the way that we have set this up is that you can type in ucdavishealth.zoom.us, and patients can be set up into a virtual clinic. The Vascular Surgery Division has a UC Davis Vascular Virtual Clinic. Patients log into this, they join a meeting, they put in their phone number. This is the phone number to our clinic. So they go into the virtual clinic by typing that in, and then they're put into a waiting room. And they wait in the waiting room until somebody from our clinic comes in and lets them in. So if we try to do that, so this is our UC Davis virtual clinic. And basically at the bottom, there are participants that are here, and then you can allow them in. So it makes sure that more than one person is not in the clinic at one time. Hello, Ms. Jones, can you hear me? Unfortunately, we can't hear you, so I'm going to ask you to nod just a little bit, okay? So again, the best part of a demo is when it goes live. It worked good yesterday, but today it didn't. So Ms. Jones is a patient from the clinic that lives in Yuba City. She gets her care down here at UC Davis. Some of you have met her, some of you have treated her. What she has told me and what she enjoys about coming down here is that living in Yuba City, she is able to get the same care in UC Davis, but she doesn't have to come down here all the time. And Ms. Jones, unfortunately, we can't hear you. So I appreciate your time this morning and that you did this for us. And I really thank you for that. So thank you, thank you. Best part of a demo is that sometimes it may not work. So this is basically how we do it. You log in, you join, set up a new meeting, you go here, you let the person in, and then that's where she comes in. So where am I going with all this? What am I doing? Where am I going? What is all this research about? When I was in the Dean Scholar program, I had the opportunity to work with OSHPD data from around California. And what I did was I mapped out amputations throughout the state. The darker the area, the higher the rate of amputations. So these are medical service areas. They're a breakdown through California. And basically what you can see is that these areas around Lake Tahoe, some of these urban areas and in the Central Valley have slightly higher rates of amputations. The blue dots are where we have telemedicine clinics. And I thought if I could access some of these telemedicine clinics, or if I could use some of them, or even build new telemedicine clinics, perhaps in these areas all around Sacramento, maybe I could change how many amputations there are over time. So Barton is one of the areas that we are working with. Placerville and Yuba City, Lodi and Manteca, Manteca and Lodi are both areas where we have tried to build or are in the process of building vascular telemedicine clinics. And back to this map. So again, the blue is where there are wound care centers, and the red is where there are vascular surgeons. So there are clearly areas that are vascular deserts. That's, just as there's a food desert, I like to call it a vascular desert. So in these areas where there are wound care centers, they do not have vascular surgeons. It's been shown that multidisciplinary clinics and wound care centers, including a podiatrist or orthopedist and a vascular surgeon, expedite care and provide excellent care for these patients. But we do have telemedicine clinics in those areas. So if I can put it all together in my research, what I can do is I can take the telemedicine clinics, capitalize on those, and build out a regional network of referral patterns so that there are no longer any type of vascular deserts. You can get your care from your home. You can get exceptional care, the care that we love to provide for patients at UC Davis. So in conclusion, reimbursement is here. It is going to get better just as soon as the federal government changes some things. Patients look to us to drive telemedicine, and this is really where all of you can make a difference. It's not nearly as daunting as it seems. A couple of clicks, you may not get audio, but you will at least get to see the patient. Patients do love it. So Miss Jones is somebody that, again, some of you know, she's my mother. She loves telemedicine. She loves the idea of getting her care here at UC Davis, but she doesn't drive all the time, so somebody has to drive her. And so it's nice that she can get her care up there. And it brings, again, the best care in California to the people who need it most. And that is because UC Davis provides that kind of care. So I'm happy to answer any questions. And thank you for your time.
Awesome work, Dr. Humphries.
Thank you.
Super
Thank you.
proud of all of this. And it absolutely is the direction that we want to go, that patients want to go. And at first it's hard to believe.
Mm-hmm.
And then you realize, oh, that's what I want. I don't want to have to drive down there for like some stupid,
For some little thing, a lot of
some
times.
little thing.
Yes, Dr. Greenhall.
So we get a lot of referrals about burns, but our big question is, what's the regulations on patients sending a picture of their wound? Does that have to be some kind of HIPAA regulation? Because I know it happens a lot, but I'm not sure if it's legal.
So it's not legal or it's not HIPAA compliant for them to send it to Google. If you have a Google address, it's not HIPAA compliant for them to send it to your smartphone necessarily. It is preferred that they send it through the MyChart system, and that's what we ask them. That's true. So the other way that we do referrals is we have the vascular at ucdavis.edu. And so referrals can come in that way too, with images of the patient information and images of it, and they can be centered and taken to maybe whoever would answer that. So right now, the people that kind of go through that email are myself and Dr. Mel, as well as our administrator. But if we have patients that send photos through there, we can connect them through MyChart or put them in their chart that way. Ultimately, it would be nice to have a referral pathway through MyChart or through the electronic medical record, and we're working on that. There's a lot that can be done there.
A lot of divisions have set up an email account that their practitioner manages or something like that to have that initial contact sent in before they are established as a patient.
Mm-hmm.
So from a referral point of view, it's a good question.
Yes, Dr. Goodnight?
Oh boy, low-level tech question. I've mastered my iPhone. I can really transfer photos very well on my iPhone, and I've used the telephone for years. How essential is the video with telemedicine? For example, could I be talking to your patient on the phone, which I've learned to pick up the audio signals, and she could send me a photo of her wound on. This all begs the question of reimbursement. She could send me a photo of her wound, which would obviate some of the tech things. I think the tech will get solved. But I've never been satisfied with these TV images, whether I'm talking to my daughter in Holland or talking to a patient on telemedicine, as you described.
No, so that's a very good point. So the couple of telemedicine visits that I've done, say, I did one with Barton. Kim Evans had a patient that she wanted me to see through telemedicine. And we brought in the camera and we set everything up, and it was a foot she wanted me to look at. I couldn't see the foot. So what we did was we took some still images and had those sent to that email address, and then I was able to communicate with the patient. And when we do a referral for our telemedicine wound care program, it requires images be sent. So they have to take images of that foot, send it to that email address, and then we do the rest of it through telemedicine. There are a couple of other things they have to have, an ABI and also a wound classification that the primary care doctor does. But that allows us to actually be definitive, because you are absolutely correct. You cannot see the wound with enough granularity. The reason we use that little camera is very easily moved if the nurse or the person in the clinic takes it off, and you can put it right on the foot. With the PT zoom cameras, you can't zoom in far enough, and it's such a big monstrosity that we felt like that really didn't work. We tested out several different cameras, little light rings around them, little this and that, for image quality and color, and this is a camera that we felt really worked well for the wound care center. So sometimes, yes, if everybody is on a great network in a clinical area, it works great. But if the patient is, or if the Wi-Fi isn't strong in one area, then what ends up happening is you can't see it very well. So we ask them to send supplemental images. So, Dr. Piera? Yeah.
Misty, thank you for that talk. I think there's a lot of potential for us in plastics and hand to implement this and to capture areas that aren't being served by plastics or hand or wound specialists. My question to you was taking a screenshot, because much of our wounds we'd like to keep a photographic record of. Can you take a screenshot? I'm thinking through the Epic system it should be okay, but through the Zoom video link it may not be okay. Do you know what the...
So Zoom is a HIPAA compliant platform, so that is something that you can do. If you are going to take a screenshot, I usually would tell the patient, and then I would tell the patient this is going to be transferred into your medical record. When they're doing telemedicine in the telemedicine clinics, most of them are on a Zoom platform. So telestroke, emergency medicine, emergency telemedicine in Lodi is done on a Zoom platform, so it all varies. It is HIPAA compliant. You have to then make sure that if you're putting it on a device, that you also protect that on your laptop that's encrypted, all the things Tawn and Manny do for us that I don't quite understand, and make sure that it's then put into the chart in that pathway.
Thank you.
And we want to help support anybody who wants to learn how to do this, and people like Dr. Humphries really have learned a lot of this the hard way. But we specifically want to make it easy for you to make this part of your practice. And even though there's a little learning curve, that it's worth it.
Yeah.
So really agree with that.
I was just going to ask, how do you see residents falling into this? So right now with the legislature, can residents do these visits and bill for them, or do attendings have to be
You
present?
can, because you're a physician. We still have to have the same linking language that we would do. But in other areas, there are, for instance, in pediatrics, that's where most of our telemedicine clinics are all based around pediatrics, because that's the people that had the grants and the money and kind of built it there. Their residents do a 2-week block of telemedicine, and all they're really exposed to is the different clinics, some of the legislation, and different areas there. So they get that exposure. They're not really doing the telemedicine, but they do have some exposure to it. And then ultimately, as they move into their more senior years, telemedicine in the NICU and other versions of telemedicine, there is this new system that is in the NICU Family Link, where the parents can see their babies all the time while they're at home. And a bunch of people can actually see the baby if you have this key and all this other stuff. So 24-hour access for the mother to see the baby, the father, the aunt, the uncle, the grandma, and like 9 people can be looking at the baby all at one time, in fact. So there's a lot of push for this, and that's where the residents are maybe interacting with it now, but it will get something to be a little more ingrained. Okay, if there are no further questions, the OR is antsy.
Yes, I saw you.
They're
Thanks
antsy.
again.
Thank you.
Thank you.